We're about to start the session, Artificial Intelligence in Ophthalmology. At the outset, I'd like to invite my chairpersons, Dr. Prakash Chaudhary from Bangladesh, to please be on the dais, and Dr. Jayagopal Agarwal to please be on the dais as chairpersons. We have our panelists, Dr. Jayashree Bhatt, Dr. Prasanna Venkatesh, and Dr. Prithvi Chandrakant. There is a shortage of chairs because of the smaller dais. So, Dr. Jayashree, please come here. Dr. Jayashree, please come here. And Dr. Prithvi, if you can adjust yourself over there. Dr. Prasanna Venkatesh is there. Dr. Prasanna, he's on the way. So, with that, may I request our co-moderator, to please be seated, Dr. Aditya Barigali. With that, may I initiate the session because our speakers has to go to other sessions also. So we need to alter a bit. Dr. Nilesh Kumar and Dr. Digvijay Singh will be completing their talks first, followed by the rest. So may I invite our first talk by Dr. Nilesh Kumar, Multimodal AI, Integrating OCT Funders, Visual Fields, and Clinical Data. Dr. Nilesh Kumar.
Thank you, sir. Thank you for this opportunity and including me in this wonderful initiatives. It is one of the few unique courses that are running in AIOC, and we are, me and Jayashree ma'am, we are talking that this in future might be one of the things that is going to come. Disclaimer: this is none of this is these are all commercially available product that I am going to talk about. It is not more about getting or making new products on my own. That is a separate topic in itself. But this is what I use in my clinic is what I'm going to talk about. How I integrate OCT, fundus, visual field, and clinical data to come. Mostly the diagnosis right now is based for glaucoma, but in future it is come into diabetic retinopathy, ARMD, and other retinal pathologies as well. So there are no financial disclosures. So it happens mostly in the busy clinic is then when you have fragmented, like perimetry report is coming, then OCT report is coming, and then in your mind you have to correlate, see there is a structural functional correlation or not. And glaucoma itself is such a confusing topic. So if something is there which can aid you in making that decision, it is not making decision for you, it is aiding you in making that decision, then it becomes very easy. So what the systems create, they create a data silo. So they will have a silo of OCT reports, a silo of fundus images from fundus camera, visual fields interpretation coming from perimetry, and your own EMR data. If you want to connect to that, it can be connected in the same system. I do it in my same OPD desktop. Everything comes to my desktop, and that prevents me, gives me more chair time to talk to patient rather than analyzing those reports, because at a glance I can see, I'll show you the printouts. At a glance I can see those reports, and immediately I can tell that there is a structural functional correlation, you are a glaucoma person, or you are going to progress into that. So what it does, the multimodal imaging, is it takes all those data points from each other and it combines and makes it into a coherent printout or a coherent output. So that is called as data fusion. On that fused data, the AI will compare with the normal thing, and it will tell that it is a glaucoma case or not. So we always think that AI is a new thing, but even if you see what the OCT was doing, or what HFA was doing, it was also a sort of artificial intelligence in a primitive form. It was a machine learning where you feed data and it compares the normal visual field with the person's visual field and tells that, okay, there is depression, there is a chance that 5% of those patients will have this kind of depressed visual field. So that was also a primitive form of AI. Now we have grown because there is a large amount of data that is there, which we call large language model. So we are just going a generation ahead in that AI which is there. So as I told, it is OCT, visual field, the fundus imaging, and the clinical data that is there. So what I use is Zeiss Forum. Lucky or unluckily, in India, it is the only one that is available commercially and widely. Heidelberg has their own setup, Topcon also has their own setup, even Optopol has their own setup, but they are not available as widely as it is. So what it does is it combines everything. I'll just show you the output for the shortest of time. So this is a comparative analysis of all those things, but as I told, in India we don't have this, we are not spoiled for choices. We only have Zeiss Forum or Optopol that is commercially available. So this is the printout. I'll just show you how the printout comes. So this is the printout that comes. So you can see there is a fundus photo heat map that comes from OCT RNFL, that is infrared image, that is on the bottom side. Above that is the RNFL heat map, and then you have the RNFL thickness map that is there, and above you can see the depression plot. So what it does is, wherever you are seeing the yellow thing, there is minimal amount of the RNFL loss, and are you getting a depressed visual field at that point or not? So the structural functional correlation, if the depressed visual field is in that area, then you are the visual field is correct and you are having a structural functional correlationship. In the right hand side, you can see the right eye is showing too much of RNFL defect, but the visual field defect is not matching. It is not falling in that arcuate defect. So it might be either a wrong field, or the patient might be having a structural abnormality but not a functional abnormality. Compared to that, this is the second case. I'm going to show only two cases here. You can see there is a superior notch that, an inferior notch on the right hand side. It is completely, the inferior rim is completely gone, and exactly at that point you are having depression in the visual field on the superior side. So I don't have to break my head that, okay, there is a functional correlation or not. You have the fundus image, you have the RNFL thing, you have the OCT, you just have to see for the IOP and just you are done with it. And with that, they are also coming up with Pathfinder, which is in the OCT, they are integrating the AI, so that it will detect at which point. So it scans the entire retina, but it will tell you at which point you have the disease. So you can just go to that point and see what the pathology is. They are not able to yet diagnose what it is, but they are actually able to localize that, okay, there is a subtle change in this area. You go and you see what it is. With that, I'll just close my talk. Thank you.
Thank you, Dr. Nilesh. With that, I'll put forward a doubt, which rather you should give me an idea. So the image quality in different machines are not the same, and if you go for Zeiss also, at different centers the image qualities differ, and the image acquisitions are also an issue. So how do you deal with that? Nilesh as well as Aditya, you can address this.
So I think, sir, the image quality, it is inbuilt in these machines, that it shows the signal strength of each and everything that we are doing. So if the signal strength is more than 7 only, then it is incorporated into this analysis. If it is below 7, it is not incorporated.
So if there is a media opacity, the signal strength is not 7, what do you do? Do you integrate?
No, sir, then it is a manual thing. We are not yet at that place where we should take that.
So that is basically the criteria or cutoff point.
Yes, sir.
It has to be an image quality of 7
and above, yes, sir.
Aditya.
So, yeah.
Yes. Do you think that it differentiate any neurological with the glaucoma?
Sir, the neurological fields are so rare that I am not able to analyze it yet. It is 1 year, but still I got only 2 neurological fields. So I am not in a position to actually tell that it does or does not do that.
Is there any classification regarding this disease progression or disease?
It gives the analysis plot as we get a GPA in HFA. So over the year, if it goes for 2 or 3 years, then it gives a progression analysis similar to that, and it gives a combined score for both structure and functional loss. So it is not only structural or functional, but combined report.
Is there any score for any what the grade of this glaucoma?
No, sir, not yet. It is just aiding into diagnosis, not making the diagnosis as yet, sir. It's not doing that.
I'd like to bring in.
Thank you.
Am I audible? I'd like to bring in a couple of points here for the benefit of our audience who might suddenly find this talk of a much higher level, who are not aware of what a single AI is versus a multimodal AI. So far we have been developing algorithms, to just diagnose one disease, like either a diabetic retinopathy, labeling the data for a diabetic retinopathy or an ARMD or a glaucoma, and getting one endpoint result. So then that becomes very disease specific, and there is always the risk of losing out on something else which might be present in the same retina. So then now the futuristic what Dr. Nilesh has been explaining is about multimodal AI, where you have multiple data points which are labeled, and then we get a more of a comprehensive report from one single input. For this, couple of things in practical things what I might think might be challenging is that if I don't want everything in one instrument, it might become too tech heavy for me. So it all based on how big is your infrastructure, how much of tech you need in it. So for institutions and all that it is okay, but if I want to just use it for teleophthalmology, peripheral screening, having OCT, everything might become too heavy is one input. And another thing is there any way you are addressing the black box while you are making these multimodal AIs? Because the black box phenomenon has been something that kind of scares us from utilizing, because AI is interpreting, but we don't know where the results are coming from. And hence, if we want to trust AI more and more, then we should be able to get an analysis of why it is saying what it is saying. So are you addressing it in your studies?
Good thing about this, ma'am, yeah, I do manual cross-checking, and this is, as I told, it is aiding into the diagnosis and not making the diagnosis as such. I take the clinical scenario in picture, the patient's IOP and the corneal thickness and other factors as well into the status, and if it is first time, then I still do the repeat follow-up at 6 months, and if it is matching, then only I start the treatment, at least for glaucoma. The first thing that you told, that multiple devices like from Remedio and Forus and Artless, they are coming up with portable devices that can be used everywhere, and that also has, because the phone itself has become so powerful that it has so much of computing power that it can handle a small model, AI model in itself. So that is not an issue right now. The thing will be with the heavier machines like OCT, where you can't port it anywhere. But the ecosystem, if it is created in an institute or in a, like mine is a private practice in a tier 3 city, still this can be done. It's not that it can't be done. The only thing is that you have to have an ecosystem, not taking one machine from here, one machine from there, and then integrating. Then it won't work. And for the black box, ma'am, still it is very early for us to say, like, the AI is not that what we call is powerful enough to tell us about the diagnosis. So that black box phenomena, until and unless we have 10 years or 12 years of clinical data, we can't say that it is going to be completely independent.
Please use the mic. Everybody can hear your question.
Is there an Indian software company which integrates different company machines?
So there are startups that are coming. Even Dr. Digvijay sir is here. He is working on one of the startup that does that. The problem is with the companies. The multinational companies won't remove the DRM, that is the digital right management, over their data output. So they are not allowing the machine's data to come out. Even in the DICOM export, it comes. You can't read it. So the problem is with unless they open up, it is impossible for anybody to get the data. So the second step will be, Shah sir is here and Kakadia sir, they are developing an ecosystem fighting against that thing, that everything should be open source and anybody can access that data. So that is the only way, I think, sir.
Thank you, Dr. Nilesh.
Ultimately, you are saying that structural as well as functional, both are very important, and you used to summarize with both the data. Then otherwise it is not possible. So actually, whatever be the multimodal AI or what is the scenario is, that you have to depend upon your functional also, and or also on your clinical experience. Thank you.
Thank you so much. With that, we move over to Dr. Digvijay Singh, real-time AI in clinical workflow. Welcome, sir.
Thank you to Dr. Debashish for this opportunity. And, apologies, my talk is going a little out of place in terms of the order because I have to go to another session. So I'm going to now talk about, AI in clinical practice, in ophthalmology practice. And we do know that, it's available now, a lot of AI models are available and people are using them individually. But how do we go about using them in our own, in my own clinical practice or in my clinical workflow? And that's what I'm going to discuss today. So in my own workflow, these are the situations where I use it. I use it sometimes for IOLs, I use it for glaucoma a lot, I use it for diabetic retinopathy occasionally, but a lot for the clinical summary. And I'll show you some of these are my own developed tools that I'm using on a regular basis. Of course, for IOL power calculations, we have the IOL calc available, which is basically using the latest super formula, which is an AI based formula. And sometimes we use this as a beta tester for them. We put in the IOL values and we see that, is it matching with what our machines are telling us. For diabetic retinopathy, I have used the software called Avenue CC, which we were using with the Optomed earlier, and I was part of helping and develop this as a part of their Horizon project. So this is again just a picture of and very similar to the IDDX DR software. It would pick up the diabetic retinopathy, a few points, it will tell you whether it's there or not and try to classify. But since I'm a glaucoma specialist, a lot of what I do is in the field of glaucoma, and I use these for not just detecting but also for progression and for the clinical workflow in glaucoma. So this is a software that we've developed called Scan AI, and this is basically now also being run by another called AI Shiro Light, which is another company which is now running it with us. So here all we're doing, this is the most simple form that I developed some time ago, where all we're doing is we're taking a picture of the fundus, a single picture of the fundus, and we're going to analyze that on a cloud to try and see that what is the change that is happening on the optic nerve head. And we score this using the DDLS scoring, or the disc damage likelihood scale. And as this is scoring, it's going to process and tell you what is the risk and likelihood of glaucoma. So here it's marked out the cup, it's marked out the rim, it's put in a probability of glaucoma, it's marked it as red where it needs to. So imagine all this is happening purely from a single fundus photo. This is not an OCT that we are doing, it's not looking at the RNFL in that value, but based on the ISNT, it is telling us, what the values are. This is a similar tool that we've got in the form of a smartphone app, where again you can take a picture from a glaucoma, from the fundus either directly, or you can upload a picture or just click the picture of a fundus photograph on a printout that you may have, and it'll give you a very quick analysis of what is normal or abnormal in the disc. So that's again something we can use, or I use sometimes in our clinical practice. This is the kind of output that we get from this AI software, and it kind of helps objectify. Remember, there is a lot of inter and intra-observer variability when it comes to glaucoma, and so this AI helps us objectify that. The other thing it does is it also quantifies inter-eye asymmetry. We know that asymmetry in glaucoma is an important marker for detecting glaucoma or for diagnosing progression. So inter-eye asymmetry in this version 1 and version 2 are picked up by this. The other place I use AI is in glaucoma progression, and what I do, I'll show you through some cases, and this is something all of us can do. We simply upload a few pictures of, let's say, the OCT RNFL on softwares like the ChatGPT or Perplexity, and they would give us outputs which look like this. It will put the values of each of the scans. So if I ask it only to analyze the right eye, because I've got one of the right eye here, the others are all bilateral eye, it will automatically pick out the right eye, put the values, tell me that there are some changes or some progression happening. It will give me the interval difference, and it will also give me sort of what we get in the visual field index. It tells us, by when the progression will, by when it will get worse the next time around, and it gives you those sort of outputs. The same you can do with visual fields. See here, we put this visual field test, and if you see here, two of the fields are of a very similar time frame as compared to the earlier. So again, it'll put the values down, the mean deviation, pattern standard, all this it is doing on its own, and it interprets that there is a visual field progression that has happened over time. It also tells you that the progression it's a fast progressor, and this would require treatment. At the same time, it will also sometimes guide you in terms of what the treatment or IOP should be. So the more parameters you give it, the more it will pick it up and tell that for you. It also mentions that the same field was repeated on the same day in the patient, and so it kind of helps you pick that inter-test variability that happens. So this is another patient where we've given the values where two tests were done at a similar time. One was done earlier, and again you get a very long chart. I'm not going to go through all of this, but the idea is that it tells you that there is a variation that is there, but it can also tell you if there's a segmental error. If it finds that the OCT is not properly done, it will also mark that as a segmentation error. Another case which sort of depicts the same thing, but here you see it is giving you very specifically that this is what was earlier. You repeated the test, you got this change. It seemed to get better in between, but again it got worse. So there was probably inter-test variability here, and that could be the reason for this. You look at this field, 2 fields done on the same, one field done earlier, then there's an improvement in the field, and then there's a deterioration. And this picks this up as a learning curve and says that, see, there was a learning curve that the patient had, so let's not interpret that field. And so the AI is smart enough nowadays to do that. Dr. Nilesh was talking about structure-function correlation, so this also would do the same. You give it a fundus image, you give it the fields, and you give it the OCT, and what you would do typically in your mind as an ophthalmologist, the machine would do that and tell you that there is a structural function correlation, one eye is progressing, the other eye is not progressing, and it gives you an output. Then let's take some action on the right eye which seems to be progressing, and particularly this is the quadrant that is progressing. So of course the reports are detailed, but very often I use this for my cognitive overload. A patient walks in with these many reports, says, Doctor Sahab, ye to dekho, ye main itni baar dikha diya, ab karna kya hai? And these situations, the AI does a very good job of quickly summarizing this for you. You can take a single photo or separate photos, they should be clear of course, and upload it, and it gives you a very good output. So the staff can do that for you, and based on this you can pick up the it will give you an output saying that this is the progression over time, it has become worse in the last 3 months, so please take action on this patient. This is a software I use which is part of the EMR voice diagnosis. Again, it's AI based. You select a part of the thing, you say what you want to say about it, it will convert into a large language module, and then LLM will then put it back into the software and give you a clinical summary or a clinical report. So this is not yet available commercially outside. This is a beta version that we are still working, an alpha version that we are still working on, but it will come out for beta testing. So this is whatever you're saying or I'm saying right now will get recorded, and it will display that to me. And at the end, it can give me a very nice clinical summary of the whole case, that this is what was said, this is what happened, this is the treatment. So it makes it very easy. I'm just saying, we did a YAG PI on so and so date. So after that, it will automatically recognize, oh, but the IOPs after the YAG PI was this and this and this, and it will mark that there because it's intelligent enough to know that. So this is just a flavor of how I am using clinical AI in my clinical workflow, and how all of us can use some of the available tools already to help us to be faster with our clinics. Thank you.
Excellent talk. Just one point, Digvijay.
Yeah.
How is it clinically accountable when I am not in tandem with the AI report?
No, so ultimately you're the master. So
Yes.
remember, you have to remember that the AI is only going to assist you, and so therefore it's your call to take. But it just helps you save a lot of time. Imagine looking at 18 reports. It will just,
Yeah. So I just have a question. In the reports of the patient are provided to you in confidence. So you have a enterprise account for Perplexity as well as ChatGPT, I expect.
yes. So you have to have an account, of course.
Yeah.
So there is sort of that dilemma that is there, but you can do it because it's not going through patient's account. You can do it if you want blinded as well. You can wipe out the tops of the reports if you want just a lot of effort to do that. It will still give you the response, but the date should be there. If the date gets lost, then the test gets then
So
can't.
essentially, I don't see any PGs, but they are the ones who taught us how to do this. It is a contravention of the DPDP Act. Please be very careful. Please cut off all the names, patient identifiers before you upload any image of any patient, even it is as so much as sending a report to your own patient by WhatsApp. Ideally don't.
Yes, but a lot of these AI tools that I've shown, which the ones that we've developed in-house, are on our own server. So
if it is developed in-house, then of course there is a whole legal process to this. So just when you are using,
no, that's a valid point. I think that's
please, as clinicians, I think we are already treading the line very dangerously. So if I live in Bangalore, so my patients are extremely legally aware. So if they see a Perplexity window open, they will not come back, and next time they'll come back with their lawyer. So
Delhi is no different.
I wanted to make a similar point over here that while it is definitely decreasing your cognitive overload, how comfortable are you to tell your patient that you have done this? Because then our patients are so smart, they can just directly go to ChatGPT, load everything, and come and dispute with you that says this and you are saying this. I have had these kind of scenarios in my clinic. So that is why we have to be very careful how much of AI we are using and how much of it we are disclosing to our patients.
The first or the second one that I showed, I think case 2, the patient actually came to me with that report saying, doctor, this is what it is saying, what should I do? And I opened it and I just kept a screenshot and I showed him. I said, see, it is also mentioning here that, this was a test retest variability. So don't, you've gone today and you've gone to another center tomorrow and you've done the same test. Don't think in one day you've progressed. So sometimes, AI can also sometimes misguide in that sense. It scares, just like Google scares a lot. So you have to take you have to rationalize it for them.
So, even in my case, like sometimes if I am able to talk in an AI language with my IT patient, he is very happy. It is like two of us like football.
Yeah.
So you can relate to things better, but then we have to be using it with a lot of discretion and,
Yeah, absolutely, absolutely.
One quick question.
Yes.
The voice module that you showed in the end,
Yeah.
it can be integrated with any, can it be integrated with any AMR?
It can. The only problem with that is that a lot of the EMR companies aren't very happy to give out that the API to do that. So we're trying to do a B2B, but ultimately the idea is it should be integratable with any EMR, provided you train it for that EMR, because you have to tell it these are the fields. So each EMR may have a slightly different field of how that's entered.
So it's more like a AI scribe.
It's more like a scribe, but the only difference is in a scribe it would scribe literally what you would say. You would say YAG-PI done, this would convert that into a thing and then say YAG-PI done on so and so day, initial IOP was this, final IOP was this, patient was put on acetazolamide. So it will cover that into a summary.
So just for those who can or who have the intention to do this integration, OpenEMR 8.0 has a patch released like 2 days back. So I think you should test it
Maybe
out once.
Yeah,
because that's essentially OpenEMR. So you could try that.
Thanks for that input.
Yeah, just a very nice presentation. So what are the prompts you feed in? Because it's all about prompts. I mean, what do you want from this patient? What has been done in this patient? Or is it just that you upload and give me a final summary or give me a verdict of what is happening or what outlet? So are there some prompts?
Prompts are very important. So for example, in that OCT where I was showing first both eyes, then one right eye, I was just wanting it to know that has the right eye progressed beyond, compared to the left eye, has the right eye progressed differently? So it will tell you that specifically. But more importantly, if you're looking specifically to, look at a particular quadrant, you can ask for that also. But in most of these cases, I've asked for a summary along with the specific question that, okay, give me a summary of these reports and tell me what has been the progression in the right eye. Specifically, that was the eye we were worried about.
So they are able to basically fairly accurately detect your OCT changes and all that. The AI is, so powerful that it is detecting each and every quadrant change.
Absolutely, and it is detecting it faster than we would. So I would take time to look at it and say. There's also an interesting thing. So I know that that an OCT would progress typically for a person with aging at no more than about 1.35 microns per year in let's say the superior quadrant. So if you also tell it that is it progressing more than it would progress by aging, it picks it up and tells you that also, that if it was just pure aging, it would have changed from here to here over the last 5 years, but this has changed from here to here. So it is the odds of it progressing more are so and so.
So have you tried different AI platforms, like which gives you the closest diagnosis?
So I've shown 3 here. But so far I found Perplexity sort of to be closest to what I want. But the ChatGPT 5.0, not the 4, is fairly close to what we ask. But again, I think it is the one you get more familiar with once you're using it.
I think it is more your use of a particular model. The more guardrails you put on it, the more you train it. So essentially I've gone from ChatGPT 2.3 to 5. So it knows there are a lot of memories that you can update. I think that's a very important thing for you to develop, to customize the model to respond to your requirements. So if you ask, if you use ChatGPT on somebody else's account, it is very likely to be very inaccurate. But in your hospital, because you've been using that for so much time, it kind of knows, because there are memory updates that are happening as you give more and more rules. So from the ground up, I wouldn't suggest ChatGPT, Perplexity, because they were not purpose built for this. But eventually VLLMs, as we come, I'll just brush through that in my topic. But the thing is, we will have AI, which is also a vision large language model, eventually purpose built for our requirements.
So the paid versions are better than the
No,
free versions?
no, because they are large language models. It is essentially a librarian or a secretary, you would say. So it is like having a secretary for 27 years who knows what PDR is right? Because they just look at those images, but they don't know why it is PDR.
I was saying, is our AI reports can be submitted to the court in medical legal? I don't think as of right now that is it.
No,
It has
they are
to
not
be-
acceptable, and essentially we are immediately in contravention of the Digital Data Protection Act. We can't disclose patient specific data even after anonymization to private enterprises. It's as good as you sharing data with Geo or anyone else. So ideally we shouldn't be discussing this on a public forum. No, I think we should specifically mention in our medical record that the patient had a summary of this, but you need to write it down. Like when a patient comes for a second opinion and there was a complication in the previous surgery, we know how we tread. It's very diplomatic. So we also don't want to say something against the surgeon, but we want to make our findings absolutely on our responsibility, integrity. Yeah. Yes. There's no escaping that fact, but I think we should start recording this in our own medical records. Yeah. Yes, sir.
Also,
Yeah. So Debashish sir is going to present Beyond Detection, a predictive AI in ophthalmology.
So also I would like to mention no financial interest here, but there is also a EMR right now in the market called Blu-ray, which is having this AI integrated voice command, and whatever you talk during the patient, it takes in and it puts the whole thing into the systemic history and all those things. Also it gives you an update on which medicines will react with others and all the timings and everything. So there is already EMRs in the market which is having voice commanded, that's a Blu-ray.
Yeah. You use it?
Yeah, I've seen the demo of it, but I've not used it, started using it.
Right. With that, we move over to Beyond Detection, the predictive intelligence in ophthalmology. The artificial intelligence has already transformed ophthalmology by enabling automated detection of the diseases from imaging. Landmark systems such as the DeepMind's collaboration with the Moorfields Eye Hospital demonstrated that AI could detect retinal diseases with expert level accuracy. But we are now entering into the next frontier, from detecting the existing disease to predicting the future risk, progression, and the treatment response. So predictive intelligence aims to answer who will develop the disease, or whether the patient will develop the disease at all, how fast will it progress or not progress, which therapy will work the best, and when should we need an intervention. So what is predictive intelligence? It goes beyond image classification. It integrates the multimodal imaging like the OCT, fundus photo OCT-A, as well as it includes the EMR, the genetics, the systemic health data of the individual patient, and the longitudinal patient follow-up. Using machine learning and deep learning models, it forecasts the disease onset, the progression trajectories, the visual outcomes, and the treatment responses. So if we come down to the predicting diabetic retinopathy progression, traditional intelligence detects the diabetic retinopathy. Predictive intelligence estimates which mild NPDR patients will progress to proliferative retinopathy, the risk of vision-threatening complications, the likelihood of DME development. AI models trained on data sets like the IPACs have shown that subtle image features invisible to the clinicians can predict the future disease severity. And what is the clinical impact? It develops a risk-based screening intervals. Somebody might need a screening after 6 months, somebody after 3 months. It develops the early prophylactic intervention, when to intervene and when not to. It reduces the overtreatment load. Coming over to the ARMD conversions and its predictions. In ARMD, predictive intelligence models analyze the Drusen morphology, hyperreflective foci, and the retinal thickness patterns on the OCT. They help predict The conversion from the dry AMD to the neovascular AMD, geographic atrophy progression rate, and the visual acuity decline. Data sets such as those from AREDS have enabled the risk stratification models. And what is the clinical impact? We developed a personalized follow-up intervals. Everybody will not need to follow up on a fixed interval. Early anti-VEGF planning to prevent complications, and the patient counseling, of course. Coming to the glaucoma progression forecasting, for glaucoma, predictive intelligence integrates the visual fields, the OCT RNFL thickness, as well as the intraocular pressure trends. The models can predict the rate of RNFL thinning, future of the visual field loss, and time to functional impairment. And what is this clinical impact? It has developed a tailored treatment escalation needed for the patients, a reduced irreversible visual loss for the patient, and improved surgical timing decisions in glaucoma. Predicting treatment response in retinal diseases. In neovascular AMD and DME, AI can forecast the anti-VEGF injection frequency, non-responders versus the responders, and the risk of recurrence. The emerging work also evaluates the steroid responsiveness, long-acting implant suitability, and this enables precision ophthalmology. Cardiovascular and systemic risk prediction from the retinal images. AI models developed by Google Health demonstrated that retinal fundus photos can predict the cardiovascular risk, the blood pressure, the smoking status, age, and sex. This positions ophthalmology as a window to the systemic health. And what is the future implication of this? The retinal screening clinics may become the systemic disease risk prediction hubs in the very near future. Technologies which enabled the predictive intelligence. Longitudinal deep learning models trained on time series data rather than simple images. Multimodal fusion, combining the imaging, clinical data, and genomics. Foundation models, large ophthalmic image models pre-trained on millions of scans. And federated learning enables multi-center training without sharing the patient data. What are the challenges and the limitations? Data bias. There is an ethnic underrepresentation in all the data. We have patients from the Northeast, we are ethnic groups, we are not included in these data and might give an false results implications. There is device variability between clinics, and there are geographic limitations. The explainability is a challenge. The black box predictions remains difficult to interpret. There are regulatory hurdles, static versus continuously learning algorithms, approval frameworks evolving the FDA adaptive AI discussions, and ethical concerns like the algorithmic bias, liability in predictive errors, and patient consent for the risk prediction. Predictive AI must be embedded into the EMR systems. So the EMR systems has to acknowledge that predictive AI is incorporated. It must be interpretable, it must be clinically actionable and cost effective. The future models in the AI triages and predicts the risk, the clinician confirms, and a personalized treatment plan has been protocolized. What are the future directions? Real-time risk dashboard, live progression risk scores for each patient will be available in the clinics, digital twins in ophthalmology, virtual patient models simulating disease trajectories, gene AI integration, predicting gene therapy response, and home-based monitoring with AI, integration of the home OCT and wearable devices. To conclude, we are moving from reactive care to proactive care. We are moving from diagnosis to prognosis. We are moving from population medicine to precision ophthalmology. Predictive AI in ophthalmology represents a paradigm shift from seeing the disease to foreseeing the disease. The next decade will redefine how we screen, how we monitor, how we treat, and prevent the visual loss. Thank you.
Thank you, sir, for this wonderful talk. We did do a study on explainable model of AI when I was just seeing your challenges. So AI has this black box dilemma. Sometimes we don't know why the way it predicts the way it predicts. So to break the black box dilemma, that is where we created a human in the loop arm we called it the Utilizing Human Intelligence with Artificial Intelligence, and we came out with a paper in IGO 2023, sir, which won the IGO Silver Award. And I think that is an idea where we can amalgamate a human in the loop arm in all the algorithms that we bring. So we will always have an explainability in the A, and we will not only have the diagnosis, we will also have why the diagnosis has been arrived because of that. So just that wanted to add it. Thank you, sir. Thank you for this
so
very
much.
Insightful talk. Thank you.
Thank you. With that, we move over to Dr. Aditya Barigali.
Can I present last? Because I have a small change in the, yeah.
Okay.
Hello.
Yes, sir. Yes, sir. You have a question.
Sir, AI is in budding stage, and at present, it is just like a soft copy of differential diagnosis for a solo person. Let doctor benefits from AI, let AI need not benefit from the doctor. The stage will come, doctor's experiences will be added to AI, and it is unlimited period that AI will have many differential diagnoses, and this small gets much complicated to come to conclusion. So, in other words, AI definitely useful provided you supply to the AI. Is it possible to add our data to AI? This is my question. Thank you.
So, yeah, currently we are at a stage where AI behaves very simply like a fresh MBBS graduate who assists us in our OPD and makes a lot of mistakes. So the journey that we pass through from undergraduate to being fellows and practicing subspecialty, all of those data points are not available to AI. It's a single track. So you have asked it to be an ETDRS image reader. So when the ETDRS study happened, we know that the readers were not medical specialists, they were science students who could grade the image because bias was a very important issue ETDRS faced. So we are at the early stage where the child is still learning to walk, and we are asking it to jump and run marathons. So that is definitely there on the horizon, but not today.
That is the reason all the regulations, everything is being put in place, sir. Because whenever something new comes, there is always a learning curve, and there is a lot of skepticism in adopting it. Like same thing happened when phaco came, same thing happened when refractive surgeries came, and it was all seen with a lot of like suspicion. But over time, they have become established practices. So we are in that stage where there is something new, which we are very happily adopting, but at the same time putting all kinds of regulations in place so that it does not deflect and bypass us. But like how Dr. Prasanna said, human in the loop. So that human, the senior doctor will always be important. It's just that the way we think and the way we work is going to be a little different.
With that, we move over to our next talk by Dr. Rajiv Raman. Dr. Rajiv Raman is presently based in UF College of Medicine, Florida. Because of the present Gulf War situation, he has to cancel his flight, and we have the recorded talk with us today. So we will play the talk. This is by Dr. Rajiv Raman, Home Monitoring and Remote AI Diagnostics.
Very good afternoon to all of you, and I would like to thank Dr. Debashish Das for putting up this such a nice instruction course. And next few minutes I'll be talking on home monitoring and remote AI diagnostics. I'm extremely sorry I could not come physically because of the Iran crisis, but hope to see all of you soon. So why do we need home monitoring? So many retinal diseases, even other ocular diseases like glaucoma, they need frequent monitoring. The clinic-based care is episodic care, while these diseases, the progression is continuous and we need to see them on a regular basis. And many patients, they present with present late with a vision loss because of access barrier, travel distance. They are elderly patient, they cannot travel again and again, and definitely there is a workforce shortage. That's the reason we need home monitoring, and we need to make a shift from episodic care to a more continuous monitoring. So what is home monitoring? The home monitoring refers to a patient operated device or a digital tool that can track ocular structure or ocular function outside the clinic. So it's important that they can do these tests at home. There are a couple of current technologies where people use it. It could be a digital Amsler grid, hyper acuity testing, and this was a device a couple of years back. It became very popular, but now not many people use it. The 4C home device, the smartphone vision apps, and structural monitoring by doing a home OCT system like a Notal Vision home OCT. And next few slides, I'll be just concentrating on one technology, the home OCT system, the Notal system. This is the home OCT, and basically the patient acquires daily OCT scans, and the Notal analyzer, it detects the fluids and quantifies the spatial fluid maps and gives a total volume of each day, which is mapped to the fluid volume trajectory. And this information, and along with the OCT scans, is seen by the ophthalmologist, and he takes a decision on whether to treat or not to treat. So there was this DR-CRNet protocol AK. The whole concept was that in neovascular AMD, we see patients every month. Even the best way to treat patient, the treat and extend, he has to visit every month. We have to treat more often. And the question was, can we reduce these visits of the patient by any way? And to answer that, there was this home OCT device which had just come up, and DR-CRNet thought of using it in a big clinical trial. Before doing that, they did this protocol AK where they assessed the feasibility of home OCT outside the clinical settings. The data was collected from the home OCT system, and that aim was to plan future larger studies. And there was the reading center data also which was used on this, and then they compared whether the reading center and the AI which is inbuilt into the Notal device is reasonably good. So it demonstrated the adherence, meaning that the requirement is that every day the patient should do a scan, and reasonably good adherence to the scan. About 6.3 scans per week was achieved. Each scan took nearly 47 seconds per scan, that is less than a minute. Most scans are eligible for were eligible for fluid quantification, nearly 86.5%. And if you look into the grader agreement with the Notal OCT analyzer agreements, it was pretty high. You can see nearly 89% the NOA detected fluid in from where there was really fluid, and when there was no fluid, 71% of them it could say that there is no fluid. This study showed that the remote home OCT is feasible and it is also reliable. Based on this, there was the protocol AO which was planned. The rationale is it's a large randomized trial to see the role of home OCT in clinical practice, and it also gave us guidance how to use home OCT, how to set fluid threshold, when to bring the patient for assessment, and basically it treated, or it tried to look for the visual acuity outcome and visit and injection frequencies by using a home OCT guided treatment versus treat and extend, the most common regime which is used in clinical practice for neovascular AMD. This is the screen, so I'm happy to share I'm part of this study as an investigator, and this is the screen which we see when the patient is on home OCT. On one side you have the patient information, then you have the B scans with a Notal OCT analyzer overlay. You also have the fluid thickness maps, and what you see here is the the fluid volume trajectories, various volumes, the intraretinal fluid, which is by blue, the subretinal fluid, no, and then we can put actually the threshold. So we put a threshold, like for this study, we put a threshold of 10%. That means a 10% increase in fluid. The patient gets a notification, we get a notification, and the patient is called. So clinician can change it because he can analyze, and if suppose the OCT has fluids which are pseudo fluids, pseudo pockets of fluid, he can increase it to 20%. Or no, if he wants a fixed visit, he can actually put a date and time after the injection when he wants the patient to come back. So definitely the retina clinic is moving towards home monitoring, and AI is making it possible. As I told you, trying to move from episodic to a more continuous care. Thank you very much for listening this talk. And once again, I'm extremely sorry for not attending this function, this program physically.
Thank you so much. Because of the paucity of time, we are running a bit late. We will take up any additional discussions at the end of the session. So with that, we move over to...
we move to Ashwin or no?
Ashwin would like to do it.
Yeah.
Ashwin is the generative AI.
So Dr. Ashwin will be presenting on generative AI for ophthalmic practice.
Good morning, and thank you, Dr. Devashish, for giving me this opportunity. I'll be talking about generative AI for ophthalmic practice. A few disclaimers: I have no financial interest here, and few of my slides have been generated with generative AI, and that has been notified in this mark over here. So what is generative AI? AI that is designed to create new original content. It can be text, images, code, audio, or video. It learns patterns using existing data, and through deep learning and foundational models, it gives human-like inputs. Examples are like ChatGPT, Gemini, Midjourney, and Grok. Now there are different types of generative AI models. One is the large language models like GPT-4, which can be used for text generation, clinical documentation, and medical education. Then you have generative adversarial networks, or GANs, which are basically two competing networks, and they have a feedback loop to generate realistic images. The generator creates the fake image, trying to fool the discriminator, and until the discriminator is fooled, the generator keeps on generating more and more images closer to reality. And this can be used for image synthesis and image enhancement. Then you have diffusion models, that is Stable Diffusion, DALL-E, Midjourney. They gradually transform noise into structured data. It's basically like a sculpture carving out, the pieces of the stone finally until you reach the actual, the model. And this can be used to generate high fidelity images. What this model does is it converts noise into structured data, and this is called as iterative denoising. And it gives you better diversity than GANs. And now the newer one is multi-model models such as ChatGPT 4.0, 4.0, Gemini 1.5, Claude 3, Flamingo. All this combines multiple text, images, everything, and it's able to understand context similar to humans, and it can be used for clinical decision support, AI-assisted telemedicine. Now, this is just basically one way generative AI works. It can combine all my slides into one, very good looking image that can be used for PowerPoint presentation. So just large language models, GANs, diffusion models, and multimodal, it becomes more interesting for the audience also. And now, why is ophthalmology such an ideal use case for generative AI? Predominantly because it's such an image-driven specialty. There are a lot of retinal photos, OCTs being taken on a daily basis, and there are so many images that it can be used to train an AI. And especially because there is standardization across imaging protocols, all this gives you structured data that an AI can learn from and then can be used for practice. There is also quantifiable disease features like RNFL thickness, macular thickness. All these are biomarkers also that can be used to help AI learn and get better. And then there's also a scope for teleophthalmology and screening potential, like other speakers have already mentioned before me. And then again, there is a lot of administrative workload that is there in any ophthalmic practice, and AI can help as a an assistant to reduce the paperwork burden and lower documentation. Now for practitioners, it helps to automate the workflow. It can be helpful to generate clinical and operative notes, summarize imaging findings, and draft patient reports from the EMR data. For education and research, it can be used for AI lecture notes, self-assessment quizzes, interactive modules for training, virtual simulators, clinical case generation, AI-generated OSCEs can be prepared. For research, for manuscript writing, for drafting, improving the grammar, the structure, the scientific arguments, literature review, it can give you automated summaries, systematic review assistance, and then again from disparate data, it's able to even generate novel questions. And for patients, how does it help? It can be used for patient education and support, translate complex terminology, simplify the language, generate multilingual patient education resources. You can have AI-generated leaflets, you can have interactive chatbots, and personalized disease education. And for policy makers, it can be used for AI-assisted evidence synthesis. It can be used to proofread and refine guidelines and documents. Now there are challenges, some of them have already been mentioned before. There's an issue with data privacy and bias, technical and regulatory hurdles, integration and cost of integrating AI into the practice, the lack of explainability, the black box that has already been mentioned, and over-reliance by clinicians. So when it comes to patient data and privacy, there is a sensitive data that is being used to train AI models, and where all this data is getting stored is basically with big tech in some server abroad. So that is one problem. Then you have algorithmic bias, like sir had already mentioned, people from the Northeast are not getting trained, the data is not available for training AI models. You can have gender bias. You can, all these black box models and limited transparency can reduce clinician trust because there's no explainability or transparency. And then in case there's a medical legal case, who is accountable? Is it the clinician, the hospital, the AI developer, or the regulatory authority? And then this requires safety monitoring, it requires clinical validation and real world evaluation. So now for my personal experience using AI, it has been something like this. I use it for drafting consent forms, I can get multilingual versions. Academic work for article summarizing and literature review. It can help me with structured academic writing. And then as a thinking partner, I can actually throw questions to it and brainstorm ideas. For professional communication, for drafting emails, improve my tone or grammar, but I still have to input the first context first. And then for content creation, if I need to put something for Instagram or Facebook, why break my head trying to make everything online? I can just use an AI to give me the the crisp text that I can use. And then for educational tools and developing presentation, this image is again AI generated. It looks attractive, it gets the work done instead of me trying to learn how to use Photoshop. And then what about the future of ophthalmology? So your multimodal AI models, there can be AI assisted surgery where there can be real-time instrument tracking. There is personalized ophthalmology where precision medicine for glaucoma, AMD, AI driven predicting models for disease progression and treatment response. And then as you can see, there is also the problems with AI. You have two repetitions coming here. So these are errors that can come which we need to be aware of. And telemedicine, it's also a future role where AI can play a role. And this is actually genuine fear that I have. There can be three options. One is where you have Terminator, the other one is where you become into those fat blobs at the end of WALL-E the movie, or the third, which you all aim to hope for, which is a more of a collaborative relationship between AI and a human. The real problem is not whether machines think, but whether men do. Thank you.
Thank you, Ashwin. I think because of the dearth of time, we will take up questions 1 or 2 at the end of the session. With that, may I invite Dr. Predictive Chaudhary from Bangladesh. He will be speaking on diabetic retinopathy AI and its applications in the tribal community screening in Bangladesh. Incidentally, he is the son of our chairperson, Dr. Prakash Chaudhary, sitting with us on the dais, and he is a practicing doctor in Bangladesh.
Cool. Hello. So, hi everyone, namaste. Today I'm going to be talking about clinical grade diabetic retinopathy AI that we built in our hospital for the people of Bangladesh. So, just like the problem in India, we have a lot of population that has less access to eye care, and there's a lot of it in the most remotest areas. So what we thought is that we would use the power of AI to help with the diabetic screening in the rural communities. So we built a deep learning model AI, but we aligned it with the National Health Service of UK, the DESP grading. So why did we do that? Because the UK National Health Service has one of the biggest diabetic eye screening program across the whole country. It's amazing for faster triage, and it also takes like less photo for like detection. So we thought instead of ETDRS, we would use the NHS DESP grading. So now in my presentation, I'll just break it up into 3 small parts, right? First, I'll talk about the model architecture, then I'll talk about the workflow, and then finally, what challenges we faced when we implemented it in the tribal communities. So as for the model architecture, we used the Redfern Foundational Model, which is one of the topmost ophthalmic model built by Moorfields Eye Hospital. So we used it to fine-tune it with the Bangladesh eye dataset. So we had around 63,000 hospital dataset that we used to train our AI. And then we definitely made sure to have the GradCam explainability, because as I told you that if the AI just gives a diagnosis, it doesn't help. The doctor needs to know where the AI is coming from. So that's why we use the GradCam explainability. So this is a very cool data set images that we have. But what's even cooler is when we extracted all the features out, this was one of the biggest annotated data set that we did in our hospital. As you can see, all the most minute exudate, hemorrhage, the new vessels, all of those were extracted out. And this was done with the help of clinicians in the whole journey. And as I mentioned about the Redfern model, this is a model that was built in UK Moorfields with 1.6 million retinal fundus images. We used it to fine-tune it for our AI. And then we also used the lesion segmentation model where, as I showed you before, all the features were extracted and then they were used to help with the GradCam explainability so that the doctor knows where the AI is coming from. And then finally, we're very happy with our results. It showed high accuracy, and then also in the lesion detection, it was able to properly detect the exudate microaneurysms and hemorrhages. So it was a very good results on that end too. And now we come to the second bit, the workflow. So we did it very simple. Nowadays, for better accessibility, everything has to be on the smartphone. So what we did, we built a smartphone application. So you just log into the app, you create the patient entry, you take the image with a portable fundus camera, and then you upload the image. The AI detects the images and generates the results offline, and then the results can be transferred to the patient in their SMS, and it's also saved in the server. Now for the second one, what's the workflow in our rural center? So a patient walks into our rural center, we take the patient data, and then we take the image with the portable fundus, and then that image is then given to the AI. The AI generates a result. But here's the catch. We wanted clinician in every aspect of it. So if there's any single doubt of the AI analysis, the technician can escalate it real time to the doctor in the tertiary hospital, who also has access through the smartphone. So they can see the AI image and they can either override or approve the AI. So finally, the patient gets a final diagnosis, and then we used it for the follow-up treatment so that the patient can get treated into our tertiary hospital. And as I mentioned, so this is our target population, the Chittagong Hill Tracts. As you can see, it is far away from the Midland and right away in the deep corners of the hills, and very poor and lack of access to eye care. So the initial challenges that we faced was definitely the language and communication barrier. As you would see in all the presentations here, even Google or even ChatGPT, they only know mainland languages or English. But we have so much tribal dialects that none of the AIs, like the generative language models right now, can't recognize. So that was a huge barrier. The second one is definitely when you're in the remote hill tract areas, there's definitely going to be poor cellular coverage. And then finally, technological interaction barrier. We're saying we're building the AI, we're putting it in the smartphone for the accessible of the patients. But if the patients doesn't know how to use the smartphone, which is very much the case with our baseline study in the Bangladesh rural areas, so then all of this is for naught. All the thousands of dollars that we spent for the AI just comes to naught. And finally, the environmental imaging barrier. And this is very tricky because sometimes when we go to the most remote corners of the hills, we don't even have a health complex. So we're just doing like an open field screening, And we know all of our AI is dependent on the imaging quality that we receive. So because of sunlight or any other thing, or like lack of illumination, you get bad images, so you get bad results sometimes. So as you can see, that's me with like a really sunlight heavy area. And then in the tribal hill areas at the start, we saw that the AI illumination was very bad. And then, but in the hospital, it was the same device and it was much clearer. So, but we did find some solutions. So first thing that we're very proud of is, the first thing that we did was, if we're going to the indigenous areas, we need them into the play. So we had focus groups with the tribal communities, and we tried to build everything around their tribal language, like the pamphlets or any health information or anything. We tried to incorporate their input into our AI. And secondly, definitely we would have the offline first AI architecture because there is lack of cellular coverage. And finally, the portable imaging countermeasures. I mean, for now, what we did, because this is a very new concept, so we did it in the hut of, like in one of the houses of the people. They're very gracious, as you can see in this image. But moving forward, we plan to implement portable tents, and we want stricter portable imaging control measures. So that's it. So that's how we build the Bangladesh's first retinal AI system. And this is a short video. Please enjoy.
No days off, no excuses, pain talk, I speak fluent. They rest, I keep moving, same goal, new bruises. No days off, no sleep, mind sharp, routine beat. You wish I repeat, every rep build belief. Alarm ring, I'm already up, same grind when it's hard as fuck. No crowd, no camera, just I and trust. I don't need cheers, I need results. I don't count likes, I count reps and faults. When
That's it. So, okay, I think it went away. But that's pretty much it. Thank you so much, everyone, for giving me the opportunity to talk. And thank you so much to Dr. Devashish, sir. So that's my dad, and that's my mom in the front row, and my grandma too. So it's like a nice presentation for me. So thank you so much, everyone.
Hello. Thank you. It's a very nice presentation.
So I have
Pradipta.
a doubt.
Yeah,
Can I
please.
ask a question? Yes. So, hi.
Yeah.
Very good presentation,
Thank
sir.
you.
So we have been practicing something like this at our setup in Bhopal as well. We have deployed our AI as well. I had a question. Is this
Yes.
Medriatic or non-Medriatic?
Non-Medriatic.
Non-Medriatic.
Yeah.
Okay. And sir, in one of your slides, you had mentioned that the technician flags the if he sees anything suspicious, he flags, and then that image is transferred remotely to the doctor.
Yeah.
Is the technician a grader as well?
Yes. So this project has been done in collaboration with input from the Moorfields Eye Hospital. So we have a vitreoretinal surgeon and their grading system teaching our technicians of the imaging standards. So this is another safety net that we put. So the AI has been already trained to the max. On top of that, if the technician sees something that is like off the AI results, he or she can escalate it to the reviewer, and they can either approve or override the AI.
Okay. And if it's an offline model, then how are you going to send it remotely to the doctor and the real time if there is poor internet connectivity?
That is something that we're definitely working on. So on some of the areas that we have piloted, there were some Wi-Fi, but on the other ones that didn't, we gave out with the AI diagnosis. But that's definitely what we're looking into, of sending the data from the plane to the tertiary hospital. But another feature that we are trying to look into is with the doctor also, we also have, like, the camp also has some doctors around there. So they give sometimes input, but definitely the offline first architecture, this is a plan in progress.
Okay.
Yeah.
Okay. Thank you. And what is your referral outcome, like follow-up? How many patients that you refer actually turn up to your base?
We made sure that, because here's the thing, right? When you implement it into the rural areas, you screen, but most of the time the patients can't reach all the way to the tertiary place. So that is a very big challenge, but on we have a privilege. So our hospital is part of the Lions Eye Hospital, like a Lions Club International. So we have member organizations in each of these hill tract areas. They take the responsibility of any patient that has been diagnosed, is provided free transportation to our tertiary hospital, and then transported back to their villages. So that's how we maintain that, like, no poor people gets like unscreened, or like, we just don't stop at screening. We stop at the full circle of treatment and then also the final health of the patient.
Okay. So do you have any percentage for that? How many percentage of patients actually turned up at your base?
Yes. So, I mean, if you are implementing it on the real field, the number of PDR cases, I mean, it's going to be around like 10 to 20%, right? So all of those people that has been diagnosed with treatment, because ours is a referral system, so normal patients are asked to come like after like a year or so, right? But anything that does require treatment, we make sure to follow up with them, and like a high percentage of them has reached the hospital.
Thank you. I do have more questions, but due to want of time, I'll ask you afterwards.
Of course, we can connect later. Thank you
Food
so
for
much.
thought for you in Bhopal.
Thank you so much. Thank you.
Thank you so much. With that, we move over to Dr. Aditya Barigale. He will be having two presentations back to back, retina as a window to systemic disease, followed by foundation models and large vision models in ophthalmology. Welcome to you, Aditya.
Yeah. So just to answer the last question, the attrition rate from diagnosis to therapy is about 18 to 24% depending on the geography in India. So Uttar Pradesh as well as LV Prasad paper. Yeah. So the median number is about 25%. Patients who are diagnosed don't turn up for treatment. So it's a known number. It's a very big number. 25%. So 25% median. It is between 18 to 34. Median number is 25. So that's an older paper. So coming to my presentation, this is going to be a small brush up about why retina is a window to systemic disease. We all know why, because it has the smallest blood vessels as well as a neurological unit. So it's a window to systemic disease. Our fundus image captures a lot of information about all of these systemic features and factors. I am not going to go into the details for want of time. The pathways that link the retina to systemic diseases are microvascular dysfunction, neurodegenerative changes, metabolic injury like lipid deposition, inflammatory pathways as we know commonly in vasculitis. So these processes mirror systemic endothelial and microcirculatory pathology. Systemic diseases with detectable retinal signatures are already part of AI workflows which are quite accurate in detecting cardiovascular risk. They are already tending towards diagnosing Alzheimer's through fundus imaging, especially with OCT images. So the imaging technologies which enable systemic biomarker detection are fundus photographs, which are both mydriatic, non-mydriatic, OCT angiography now to look at choroidal capillary remodeling as well as dropout, adaptive optics imaging, though it is in a research mode, has still not reached commercial level. The technology on the horizon is hyperspectral imaging. Basically one image taken across wide spectra of light shows metabolic as well as biochemical tissue signatures. Commonly we see this as fundus fluorescent, the autofluorescence images. Oculomics and artificial intelligence is the upcoming field where we use retinal imaging to infer systemic biological information. Deep learning models can predict cardiovascular risk factors using retinal photographs. So they have demonstrated even prediction of biological age, diabetic as well as kidney disease risk. So retinal imaging is emerging as a non-invasive systemic biomarker platform. So I will be jumping from that to the second talk, from retinal biomarkers to generalist AI. I think this is where I will like to go slow. So essentially currently available AI models, what we can use in the clinic are single task AI models. So we are going from there to foundation or large, very large vision language models. Similarly, where we graduate from MBBS to our post graduation and then to fellowship, we start learning more and more about less and less until we know everything about nothing. So essentially the clinical reality requires the models to generalize across diseases, devices and populations. Any ophthalmologist can infer on a fundus photograph taken on any fundus camera, but still the diagnosis is right. AI can't do this yet. So the foundational models represent a shift toward general visual intelligence in ophthalmology, which is roughly about a PG grade diagnosis. It misses a lot of times, but when it is right, it is usually right. So the goal is not to replace the clinicians. This is the chief sentence you will take away from this talk. We are not going to replace the clinicians yet. We are not there. So we are going to augment clinical triage and screening and bridge the diagnostic gap that we face because of heterogeneous screening programs across the country. So the evolution of AI in ophthalmology, we know currently it is a single disease detection. It is usually vendor locked. You have to buy the device and it has its AI in it. So these models require large label data sets for each specific task. The performance has declined when new populations or imaging devices are brought into the system. Clinical practice requires that it has to handle multiple diseases simultaneously. The same image can have glaucoma as well as diabetic retinopathy, and it still has to have high accuracy. Foundation models are technologies which are currently attempting to learn this generalizability using retinal images. So they have been developed partly because the traditional AI models have remained task specific and lack this generalizability. So I will just go through this. Traditional ML is, as I told you, one model per task, data hungry and very limited context. It means nothing to the patient. So foundational models are one model which does many tasks. It learns these patterns at scale and is able to amalgamate and compile a diagnosis similar much to the way how we think. I think even the multimodal which was discussed previously is part of a foundational model. The more parameters you can feed it, the more accurate it gets, because it is going to compile a diagnosis rather than come to a diagnosis by hit or miss or trial and error. It also adapts to new scenarios with minimal additional training. So currently we will go to the new directions. Foundational models are likely to augment screening and triage rather than replace clinicians. They may reduce the cognitive workload during large scale population screening as demonstrated previously. Most value for these models lies in prioritizing high risk patients for specialist evaluation, at least in our scenario. The treatment planning has to remain clinician led and context dependent. We have to sign off on the final decision. We cannot use AI to supplant our decision making process. The careful validation is required before routine clinical deployment because the AI is built over a very large generalized model. So it passes the exam, but it's not very accurate. It doesn't get first rank. So the current evidence suggests that these foundational models can support diagnostic workflows, but they still require expert oversight and clinical validation. In engineering terms, it is called HITL, human in the loop. So essentially, there is a guy passing chits in the exam through the window. So that is what human in the loop is doing for AI. The key takeaways from this is, the retina, as we all know, provides a direct, non-invasive visualization of the systemic, microvascular and neurovascular health. Retinal imaging biomarkers can reveal cardiovascular, metabolic, neurological and renal disease risk. Advances in imaging and analytics are transforming retina into a systemic biomarker platform. Foundational models as clinical AI infrastructure represent a shift from single task algorithms to generalist ophthalmic AI. Large vision models trained on massive retinal data sets can provide multi-disease detection and cross-population generalization. Currently in clinical practice, they will be most valuable for reducing our workload through triage and screening rather than autonomous treatment planning. So currently our program seeks to develop a foundational model across Indian populations at the Indian Institute of Science. I am the program manager for the retinal disease detection, also a vitreoretinal specialist. So I have sacrificed my clinical career for about a year to see this happen. I invite questions and suggestions.
You talk. I'll ask a question on this after that. Okay.
Thank you, Dr. Aditya, for that insightful discussion. It was so nice to see a lovely group of interested people in the audience. And I'd like to take this opportunity to invite you all for the technical skill transfer courses that we've been conducting in the training hall, TSTC and SSTC workstations. Trade Hall 2, today 1:30 to 3 o'clock we have hands-on experience with the Forest devices, and tomorrow with the Remedio devices. No financial interest. They have always volunteered to bring in their instruments and give us a hands-on experience. So I welcome one and all to be a part of this TSTC today as well as tomorrow. We now open the house for questions.
No, one point, Aditya. What I'm concerned is about the ethical data governance, particularly the privacy of the data and who owns this data once it is uploaded onto the AI system.
Okay, so at least in our program, I can speak for ourselves. Currently, the DPDP Act is very clear about this. There is something called as a data principle. The patient is the data principle. No matter how much informed consent you take, they own the data finally. So whenever this particular image or their parameters, whether it is a diabetic record or a fields test, is provided for development or eventually even for using it to make reports, it has to be anonymized. So we are
you have to anonymize the whole system.
We need to do that. So there are two ways to do it. There is what is called as destructive anonymization, where the name and the PIIs are completely hashed and you cannot retrieve the data. In our program, we are not going to do that. Even pseudo-anonymization, you can derive the patient out of a particular location. So we don't collect their name, we don't collect their date of birth, we collect only the year. So by this UID, only the hospital is able to convert that back to a particular patient. So from the model build perspective, we neither own the data nor can we identify the patient. So that way we are in the clear. Going forward, because it is very vague, I think we should tread very defensively when it comes to handling of patient data, especially when we are starting to use AI models and inferencing them using vendor AI. For example, Remedios platform, Medios, is ABDM compliant, it has M3 compliance, but if there is a breach, there is a possibility that this particular data can be used to identify a person. So their insurance premiums go up, and that's very significant as a risk. So we need to address it in such a way that all our data, what we store, is in India. So my program stores patient data here in IIC servers. We don't use the cloud platforms which are commercially available.
Correct. Yes, please.
Sir, when I was working with Dr. Carol Cheong in Hong Kong on oculomics only,
yes.
So I saw they were detecting diseases which are not very prevalent.
Correct.
How do you think oculomics in India holds in the future?
See, essentially, we would be the largest cohort of normal as well as physiologically varied people, I would say, not patients, people, to develop such platform. The amount of data that we can produce is immense. Essentially, if you go to any hospital, even your own, you will see that our images are just a random dump. We don't enter the data, individual fields of those, each image is usually empty. So unless we structure the way we collect data, it is going to be very, very difficult even for us to learn, forget about AI. So when we want to go and present on a conference and you want a disk which has an inferior notch, it takes 3 days to find it. So that reality is a clinical reality for us. So it is better that we start structuring data which will help us first, rather than looking at development of AI and all this. So structured knowledge is always useful. Now whether you're going to commercialize it or whether you're going to use it for teaching your PGs is left to you. So I come from that direction because essentially I come from an educational institution which has lot of data which is unstructured. So we are trying to build machine learning models, not AI, to structure our data and sift through it. You can think of it like a data sieve. So a lot of us are sifting through biochemical reports, fundus images, all of this. I think we should start using all the data fields which were provided in ImageNet, in TopCon or Forum to make sure at least a differential diagnosis is entered so that you can search easily. I think that's the first step.
So what they had there in Hong Kong Eye Hospital, so they used to take photos, fundus photos from 3 different cameras. They had 2 Opta imaging, and they used to store every data, and then they used to train their model. They
Correct.
also had this MTA signed with us
So
as well.
that is okay. So we will be discussing about what is called as multi-shot. Basically, iClip is the modality which they use. It is called zero-shot training. Essentially, you and I are zero-shot training because we have been given text. We can draw a retinal image. Essentially, that's what we did in practicals. So if you say PDR, you can actually draw a PDR image. So these are rule-based. So there are certain AI models in foundational models which can do that. The main issue is it needs enormous amount of data to do that. For example, if you look at just stable diffusion or DALI, to get a good image without 6 fingers is very difficult. So in Singapore, in the UK, and in some European countries, the data structure of all the patients is easily available. They have a sort of a national registry where most of the values longitudinally are filled. They may have gaps, but they are filled, they are available. We don't yet have such a system. That is the reason why somebody is able to do it, and we are not yet there. So do I answer your question adequately?
Yeah, yes.
AI is a very hot topic. It is a very vast topic. We can have an entire conference on AI.
Correct.
And the discussions are, they could go on and on. Just to add a little about, you might have various experiences from the West or from the other countries, which we have to definitely take in and extrapolate for our population. And within India itself, there is so much of diverse data. A little bit I wanted to add on the regulatory part. What Aditya sir was saying was that now AI has been brought under the umbrella of software as a device, and it falls under the CIDSCO. So there are classes C1, C2, C3, and then based on if it is just for screening, the level of seriousness is low. But if you are going to base some of your decisions in clinical work based on them, then the seriousness is high. So they would have to have a very strong permission from the CIDSCO to be able to have the license for usage. Dr. Aditya?
Yeah, so it is better that we avoid mention of AI in our diagnosis anyway. We have to say it's a clinical decision support tool. Like how would you use OCT? You will take the image, then you will infer on it, and you will decide what to do. You will not take the suggestion of, I mean, we have seen this happen multiple times, isn't it? So we have a second opinion. You will give back the report to the patient and say, I will take my decision based on my findings, because you came within a particular time span which the disease could have changed. So this is very crucial we do this, because Indian law is still not very clear how AI fits into healthcare. So it is better to be defensive than to...
These generative AIs that we have, Dr. Ashwin touched upon, how he is using it as his secretary, as a second brain to help him out for content and all that. You can play around as much as you want, because to just let go of the fear of AI and become familiar with it. But when you are actually applying it in practice, there has to be a lot of due diligence, where you are going to mention that you have used a certain tool, and up to what level of seriousness are you applying. All that I am saying is you can use artificial intelligence, but always keep your intelligence as the first thing, and we can never snooze our intelligence off.
One thing I want to add, because we have heard about the diabetic retinopathy, glaucoma, ARMD. In these topics, AI just only helps us, but we do not go for that whatever he will tell, that we will follow. It is better to use our application, but only one field, that is IOL power calculation. In the last decades, there is a major shift from older version to the artificial intelligence version, and also the data processing. And JCRS in 2025 has published a very good article in this, has divided all artificial intelligence, ray tracing, and also the versions formula. But they concluded that we have to depend upon the website of that those formulas. Totally it is artificial intelligence based. For even the Barrett calculator also shifted to artificial intelligence based formula. So in that situation, when we calculate the IOL power, it is better to go for those website. These are all artificial intelligence based. So in that situation only, that we can use the IOL power calculation power, and we can get the very accurate result. But in other field, it is very difficult. We have to put our mind first, then we apply the artificial or generative AI discussions. So it is better to use in artificial is based in the IOL power calculation only. But for the other, we have to put our intelligence first. Thank you.
Thank you so much, sir. Prithvi, anything you want to put in? Dr. Prithvi? Anything? Okay. So, may I have the concluding remarks from our chairperson, Dr. Prakash Chaudhary? Yes, please.
So we are talking about IOL power calculation. So in adults, usually it's the optical biometry what we do to have everything accurate. Can the same be applied in children who are with the biometry done under GA and you're doing with a manual scan? Because the results are going to be different. They are not focusing anything. They are under GA. So I do, it will be so subjective. You do, there will be a difference in the axial line. So can that same platform be applied in children to get a...
No, in children.
You can't. See, the thing is, I just wanted to add to what Sir was saying, that please look into the technology it is based on. If it's a DL model, deep learning model, there is very little explainability and variation throws off the accuracy by a mile and more. If it is a machine learning model, it is just an advanced statistical test. So essentially IOL power calculation is a regression model that most of us have used, that it falls somewhere in that gap between two lines. The outliers are cut off, and that's the band in which the IOL power is expected to have. That's why it's called expected lens position. Now in children, a normative data does not exist because each child grows at a different rate. Now adults, we expect them to be similar, but they are not truly. That's why the regression model has a funnel at the end for adults, but for children there is no funnel at all, it's a broad band. So in IOL power calculation you are really in the dark, it's a shot in the dark, especially if you are going from mathematical model which is fairly approximate, you are like very off the mark using even a ML model. So ideally variability of children, especially you need to do this for children who have other developmental abnormalities. So please do not get into that controversy, because it explicitly says this is in adults of this particular age group. So those powers wouldn't hold good.
There is one beautiful article published in JCRS in 2022, as most of you must be knowing, that is rule of 7. In that it has given slight edge over whatever we are doing in our practice. It is, as you know, there is a target refraction plus age is equal to 7. At that formula, you can add whatever the results will coming from your biometry or any other. It will give you some, and ultimately it is very difficult to get the correct power when the child will grow to in adulthood. So, but in that article in 2022 it was published. It is still recognized by all.
Yeah. So my just case was that if we do manual biometry and we put in lot of data, okay, this is with this biometry I got this much under correction, and maybe do maybe 1,000 kids, and can we put that thing into the AI that this is how we got it, and because obviously we are not doing optical biometry in those kids, but we have a data set of about 1,000 patients by a single person, and then you're seeing the undercorrection what we got. There would be surprises, I mean, considering all the factors, but can that be a model for future models?
Sir, if you go to the ECRS site or ASCRS site, in both sites you will find the IOL power calculation. It is updated, and in that it is also it is very that one we just insert the data from your biometer, any optical biometer, and you will get the 4 or 5 to 7 formulas result at one go. That will just we can compare it with other, and we can find out the almost correct answer, correct IOL power from this. In both sides, that is the ACRS site or the ECRS, both the data site is available.
Just taking the axial length basically.
Yes. So you can potentially do this, but please keep in mind that if in case there is a collaborator who is going to do this for you on the engineering side, it is likely that it is going to be hyper accurate for your location and not for anybody else. So that is the chief problem with AI. So if let us say you are taking it from a cohort in Delhi or Punjab or South India, the model will lose accuracy across the geography simply because those children were not part of your training data.
No, they have exceeded. I
So
don't know whether
that's a very dicey situation. See, like Hill RBF or Barrett's is applicable worldwide because it's under the assumption that the eye does not grow for a person who is 50 years of age. But in a child, the longitudinal progression and variability, if it is not accounted for in the training part, it will not be accurate. So ideally, I would still be very, very skeptical about AI use in children, especially. Retinal images is a whole different ball game because the picture is more or less the same. Thank you.
Yes, sir. So in the mics.
Sir, this is not a question, my personal experience. You are an old man, your human intelligence is excellent, but your way of expression, commas, full stops, apostrophes are wrong. First corrected your English, IJO said. Then I contacted English professor. He charged 2,000 rupees and he took 1 week time. This happened 10 years ago. Now, the same thing I applied to WOC. I asked my daughter in UK, you get corrected before I apply. He said, Dad, it is very simple. You are an old man, I am young. You go to AI. That will correct. So, WOC has accepted. This is the power of AI. As Sir said, human intelligence is first, next is AI as a second intelligence. Thank you very much for giving this opportunity.
Thank you, sir.
This is my personal experience I am telling, sir.
Thank you so much. With that, may we request,
thank you so much.
Chairperson to give the final concluding remarks.
Okay. Actually, I have nothing to add, but it was a very great and interesting sessions. We have wonderful panelists, speakers and audience. And initially I thought that it will be one of the boring sessions, but at the end I am astonished. They make the session so interesting, and we are running more than half an hour live. So I say thank you to all speaker, panelists and audience to make these sessions more interesting. But not least, I express my heartfelt thanks to Dr. Debashish Das to include me and my son in these sessions, for giving me opportunity to use this platform. Again, I say thank you to all, everybody. Thank you so much.
May I request all my faculties to be on the dais for a group photograph, please.